Okay, so this is the second part of the recording on the resin composite lectures. And whereas in the first part we talked about composition and classification and the different types of composites, in this part we're going to talk about what are the current challenges and what some of the properties of and how some of the properties of the composites relate to those current challenges. So mainly we're going to talk about hydrolytic and enzymatic degradation, polymerization stress, and adhesive interface degradation, which are the biggest problems that we face with composites these days. So clinical studies have demonstrated that the average lifespan of a composite restoration is about 6 to 7 years, and the main causes for failure are fracture and secondary caries. So that means that either the composite itself is degrading to a point where it can't withstand any more of the mechanical loading, or the interface is somehow getting degraded to the point that there's caries infiltration or secondary caries developing in the gap between the tooth and the restoration. So this is very important because this is not the case with amalgam. So compared to amalgam restorations that can last upwards of 50 years, I actually have some amalgam restorations in my mouth that are 30 years old, and they're not coming out anytime soon. But that is because they're fairly small. I'm a dentist, so I do brush my teeth correctly, and I take care of my oral hygiene. But on average, those restorations last longer than composites. And what we're trying to overcome now with research is exactly that problem of composite degradation, either by the enzymes that are present in saliva or in the tooth itself. So polymerization stress is another problem that has been given a lot of attention in the past 20 years or so. Dr. Farrakhan has a lot of papers on evaluating polymerization stress of composites. While I was his graduate student, I also published a few papers of my own on that subject. And we're going to talk in this class, to the aspects of that problem that pertain to the clinical practice, which have got to do with the network formation, obviously, but also with some of the techniques of the placement techniques that we use. So polymerization shrinkage, and polymerization stress represent an immediate challenge to the bond interface. What is represented here is a composite restoration that's a class 1 that's placed on the tooth, and you can see that this is a highly static restoration. You can barely see where the margins of the restoration are. And what's important in here is that the shrinkage that's taking place is making the composite contract or move towards the end or towards the middle of the restoration, which means it's pulling away from the margin. What that means is that in this red line around here, what you are seeing is a gap that opens up between the tooth and the restoration, and that is a place where a lot of bacteria can thrive and form a secondary biofilm. So you see here in this example, I'm actually going to go back to show you that this is a in vitro test where we had a premolar and a cavity prep was cut, and then a composite restoration was made. And then you can see that this is enamel margins and this is dentin margins. Then we put the tooth on some methylene blue dye, and you can see that there's a lot of infiltration of that dye, towards or along the margin, and you see that's more prevalent close to the dentin than to the enamel. And you probably remembered as well from the adhesive lecture that it's a lot easier to bond to enamel than it is to bond to dentin, and the bonding is a lot more reliable over time to enamel than it is to dentin. But one of the causes for this, because that restoration was not subjected to any carcinogenic challenge, it was not stored in the presence of bacteria or anything. The only thing that we can relate this to in this case is the polymerization stress that made a gap, as you can see from the micrograph, at the interface, and this is a blown up image where you can see this gap that's being formed. And this has been correlated in many studies with increased microleakage and in vitro caries formation. So if the stresses are greater than the bond strength of the adhesive, those gaps are eventually going to open up. So the clinical consequences of that are post-op sensitivity, because obviously you have a gap that's open in there, and through the hydrodynamic theory that we talked about in class before, that the nerves and nervous cells extensions are present in the dentin tubules, and so whatever movement of liquid inside of the tubule presses onto those cell elongations, and then the patient feels pain. It also causes marginal stains and leakage, as you can see in this restoration right here. It can cause tooth fracture depending on, so you see the line of fracture that's being caused by the contraction of that class 5. So that has got to do with cavity design. So if you don't design the cavity carefully, the composite starts to shrink inside of that cavity, and it can actually fracture the tooth. And it can also cause secondary decay, but there's not a clear correlation between the opening of gaps, the polymerization stress, the opening of gaps, and then the formation of secondary decay, because that has to do with other bacterial factors that are involved, to the point that there are some patients where you observe the gaps but you don't see secondary decay. This is also the reason why some of the low-stress materials that I talked about at the first part of the lecture did not prove to be superior clinically to the conventional ones, in terms of the ones that were proven to have less stress in the lab did not prove to cause less secondary decay in the clinic. The other thing that you can see here are those white lines, and this is what we call an immediate gap. And this is a class 5 that you can see. And where this was placed, this was all in enamel. Mind you that this was all in enamel. You can see the rest of the restoration here. That's actually some flashing that you should not leave in place. But you can see that this is an immediate gap that's being formed. If you see those white lines here, you know that you need to come back and either add more composite or replace the restoration, because you know that something went wrong. And you don't want to see those immediate gaps that are visible with the naked eye. And here's a comparison between, if poor technique is used in a couple of years, and the difference between those two pictures is about 5 years, you can see that there's a lot of infiltration and a lot of stain. Class 5s are really challenging to restore because of the geometry of the cavity, and because they're so close to the gingiva, they're very likely to be have at least one of the margins in cementum, which is very hard to restore. The other thing that stress correlates to is with the C factor, or the cavity configuration factor. And this is nothing more than a geometry factor that correlates the amount of bonded surfaces to non-bonded surfaces. So for example, in this case, this is a class 4 restoration. It's represented by this diagram, only one of the faces of a cube. So if you think of a cube, only one of the faces of a cube in that box, in that cavity box, is actually going to be bonded. So the C factor here is very low compared to a class 5, as I was just showing you, where if you think of the restoration of a box, you see 5 out of the 6 sides of the cube are not free surfaces, they are bonded surfaces. So this guy here, Felser, came up with this cavity configuration factor, and he was able to correlate the configuration factor with the amount of stress that's developed. And according to this paper that's been cited, I don't know, 1,000 times already, over 1,000 times, in 1987, he was able to show that the higher the C factor, or the more bonded faces you had in a restoration, the greater the stresses will be. So this is why initially it was we were recommending that you do something that's called an incremental technique. So instead of using, there's 2 reasons why you do that, but the way it relates to the C factor is if you have the first increment that's less than a millimeter thick, right? You have all those walls that are bonded, only this that's that's not bonded. But you do a second increment that's kind of an inclined plane like this. So you have two walls. So if you think about this in 3D, you have two or three walls versus having all five. So the idea with this is that you're going to get less stress developing because the material is not bonded to all the walls simultaneously. There's some studies with finite element analysis and some other in vitro studies that were not able to correlate the amount of increments or the inclination of the increments with the amount of stress that gets generated. But that's still the clinical recommendation, is for you to not involve all the walls at the same time, just to be on the safe side. The other reason why we do incremental technique is to guarantee adequate cure. So if you try to do, say, if this is a cavity that's got 5 millimeters in depth, and you try to put all the 5 millimeters of composite at once, chances are that the light's not going to penetrate past the second or the third millimeter to the same extent as it does on the top. So the reason why we do millimeters that are always less than 2, or we do increments that are always less than 2 millimeters, is to ensure that you have at least 16 joules, and we'll talk about how to calculate that value of energy going through the composite. So stress, there are ways of managing the stress in the clinic, and this incremental technique is, even though it's up for debate, is one of the proposed mechanisms through which you can control stress development. There are ways that you can control the stress on the material side, so the manufacturer side. So for you to do that, you need to understand what are the factors that affect stress formation. So obviously, the more shrinkage you have, the more stress you're going to have. Because the more the material shrinks, the more it pulls on the cavity walls, and then the stresses are greater. The shrinkage correlates with conversion. So the more conversion you have, the more shrinkage you're going to have. It makes sense. The more monomers are tied together into a network, the more dense the network will be, and therefore the less volumetric shrinkage you have. But obviously you don't want to reduce conversion to reduce shrinkage, because that would leave you with unreacted monomers, and you would decrease mechanical properties altogether. So you don't want to mess with conversion when you're dealing with decreasing stress. The other thing that makes the stress go up is higher stiffness. So the higher the elastic modulus of the material, the higher the stress. So obviously this is a property that's also desirable. So you don't want to reduce the stiffness to reduce the stress. So the only thing you're left to do is just either reduce the shrinkage by itself or reduce the stress, but not mess with conversion or stiffness. To reduce shrinkage, as we talked about, you can use a higher molecular weight monomer, which is what some of the manufacturers have done. You can use pre-polymerized particles, and there's a lot of research in nanogels and polyurethane oligomers, which in our lab, that show that there's less shrinkage and less stress because of that. Or you can decrease the molar shrinkage coefficient, which was what 3M just tried to do with the Filtec LS, that polymerized through an oxirane ring opening polymerization mechanism. So those are all valid, and they do reduce stress. There's ways that you can do to reduce stress itself. I'm not going to go into all of those because those are heavy polymer chemistry concepts that are not pertinent to the class right now. But there are some functionalities on monomers that you can do that where you delay gelation, you induce a heterogeneity, or you introduce network rearrangement moieties that are able to reduce the stress directly. What's important for you to know is that there's many developments in the research realm for those types of chemistries. One that's dealing with network rearrangement is actually available in a commercial material. And we can talk about the commercial materials and how those things work in class later if you want to. So now we're going to talk about mechanical properties. So we talked about stress and how that relates to different clinical outcomes and ways that you can do to reduce the stress, and how that can predict to some extent the health of the bonded interface. Now we're going to talk about mechanical properties, because remember, one of the things that causes the materials to be replaced are secondary cares, and the other ones are fracture. So properties are directly related to the degree of conversion and the filler loading. So in this series of slides, we're going to look at different mechanical properties. Those were all collected by Dr. Farrakhan a few years ago. And what you see here is the fracture toughness graph that's showing here the fracture toughness in the y-axis, and then the types of materials here on the x-axis. And also the colors here are coded for the microfill, nanofill, minifill, and midfill types of restorations. And you can see that clearly the highest fracture toughness, that's actually close to 2, is given by the midfill materials, and those are materials with the larger filler particles with the higher filler loading. As you go from the minifills to some of the nanohybrids and some of the minifills, they fall more or less within the same category, with some of the nanofills being at the end of the spectrum. And you can see that even though those materials classify, they have the same classification. So if you see the steel color versus the steel color bar here, you see that they're both nanofill and nanohybrids, but the fracture toughnesses are really different. The thing is, all of those are between 1.8 and less than 1, so between 1 and 1.8 megapascals per meter squared. And if you compare that with amalgam, the fracture toughness is actually pretty close to amalgam. It's pretty close to porcelain, which is just a static type of recovery porcelain, but it's a lot less than alumina and zirconia, which are the materials which full ceramic crowns are made of, and it's much lower than gold alloys, for sure. They're much lower than gold alloys. So the difference is the indication for composite materials, depending on the type, is just for small direct restorations, obviously not for crowns. The fracture toughness is an important property because there's been correlation with clinical performance, and even though those curves are it's not a lot of points in the curve, there's only 4 points in the curve, there's a clear trend for the cumulative failure of microfills and so there's 2 types of microfills, so two different materials at the same time. So there's a clear correlation between microfills and hybrids in relation to the fracture toughness value here on the x-axis and the cumulative failure clinically. And the reason why there's not that many points is because clinical studies are really hard to do, and usually, you have to have a very robust statistician working with you to be able to draw conclusions. But this is a clear trend that microfills produce more cumulative failure, and that has to do with how much fracture toughness they are able to produce. This is a table that was very nicely put together by somebody at the Biomaterials Department at the University of Michigan, that correlates the coefficient of thermal expansion, the thermal conductivity, the water absorption solubility, the elastic modulus, tensile strength, compressive strength, and hardness for different types of composites. Microfills and hybrids being the 2, and then natural and amalgam as a comparison, and the natural tooth, either dentin or enamel. So you can see that the ranges, there are ranges of properties for each one of them. You don't obviously need to memorize this, but as a comparison, for example, between composites and amalgams, you see that all the mechanical properties for composites and amalgams, some of the properties are obviously lower. So composites have a lot less elastic modulus than amalgam does. The tensile strength is not that much lower for the hybrid composites compared to amalgams. They actually fall within the same range. The compressive strength is more or less the same. The hardness is obviously lower for composites than for amalgam. And you can compare this with a natural tooth structure. So in some instances, you see that the hardness, for example, and the compressive strength and the tensile strength in elastic modulus, not the tensile strength, but elastic modulus of dentin and hybrid composites are more or less the same. So this is a material that is closer in properties to dentin than amalgam is, which might have some advantages mechanically when you're trying to load the assembly of composite, if you think about the assembly composite tooth structure. Where, as we talked about for Adaptic, that material that was the super conventional microfill, is still a concern for composites. It has decreased. This concern has decreased significantly throughout the years. It correlates, it's obviously greater for composites than it is for amalgam. It correlates with the degree of conversion, so you have more wear if you have less degree of conversion. It correlates with filler size and type, so the larger the filler, the greater the wear, and we will see a picture about that in a minute, but it also correlates with that cartoon that I showed you for the large particle composite in the first lecture. It has to do with the size of the restoration, so you have a lot of wear if you violate the 1/3 of the intercuspal width for the size of the restoration. It's worse for posterior restorations. It depends on the occlusal loads and for functional habits. So if the patient is a Bruxer, there's obviously more chance of wear. And it also has to do with patient diet and oral hygiene. So a lot of acidic foods and a lot of hard foods will also accelerate wear. So this is a cartoon that shows you that explanation of wear related to filler type. And on the top, you see larger fillers. On the bottom, you see the smaller fillers. So for the larger fillers, what happens, as I explained to you before, is the large fillers, as you're chewing on top of the restoration, the large fillers get plucked out of the surface and they expose the organic matrix, which is very soft. When that happens, the organic matrix ends up being worn off and exposing additional filler particles like this. Those eventually get plucked off, exposing more of the organic matrix. So this is a vicious cycle that goes on, and you end up with more wear, which is not as bad for smaller, finer particles. This is a study that's correlating the free wear with the size of the restoration and the location in the arch. So red bars are premolars, blue bars are for molars, so the molars are subjected to greater occlusal forces. For small restorations, it doesn't matter if you're on the premolar or the molar side, but as you increase the size of the restoration, the wear gets worse in the molar region than in the premolar region. And there's a lot of papers that are pretty old, actually, that have demonstrated that this is true. This has not been done, to as far as I can tell, with more modern composites. This is a study by Dr. Farrakhan and Dr. Mitchum, who passed away a few years ago and used to be in our department. And what they did was to correlate the wear with the degree of conversion of restorations. But obviously, you wouldn't be able to put, purposely low conversion restoration in a patient's mouth. So what they did was they made this contraption type of restorations into full dentures, and they got volunteers to wear them for a number of time, for a period of time. And they were able to correlate the wear with the degree of conversion. So as you increase the degrees of conversion here on the x-axis, you see a decrease in wear. And there was this pretty strong correlation. This is done clinically. It's a pretty cool paper that came out in JDR in 1997. So water sorption solubility is another property that correlates with the presence of ester linkages in the methacrylate. So the ester in the methacrylate is susceptible to hydrolysis and degradation by the action of esterases that are present both in the saliva, and they're also products of the metabolism of bacteria, and they are also present in the dentin and trapped in the dentin. And over time, the water absorption and solubility, which just means how much water you take up and how much material gets solubilized and leached out to the cavity. Over time, that relates to the loss of mechanical properties, the discoloration and staining, and some biological concerns, because some of those leachates can be toxic, or not toxic, but cytotoxic. So the more water absorption solubility, the worse the performance of the composite. So what this graph is showing is that polymerized resin composites and virtually all individual components have demonstrated cytotoxicity in cell culture. So in general, toxicity is dose related. So the greater the concentration of that compound, the more cells are going to die. The effects decrease over time. So as you leach out everything that's not bound to the surface or not bound to the network, over time the cytotoxicity tends to decrease, and the toxicity decreases as the degree of cure increases. So this is very important. The more conversion you have, the less toxicity effects you have. What this graph is showing is the cumulative. It's the cumulative leachates from a composite in either water, which is that green line here, or ethanol, which is this red line right there. And you can see that there's a burst release in the first 3 hours of whatever it is that you're releasing. It's worse with ethanol. But as the hours go by, so up to 1 day, either regardless of the solvent that you're using or regardless of the diet of the patient, it tapers off. So there's no more release at 24 hours. If not, oops, I did not want to do that. So there's not much more release at 24 hours than there was at, say, 3 hours. There's a little bit more, but not too much. But the point with this graph is saying that the elution and the leachates are essentially stabilized by 24 hours. So now we're going to talk about other clinical considerations that pertain to composite selection, and we're going to see a few studies where we're going to correlate whether low shrinkage composites are really beneficial clinically, what are the causes of failure, and then we're going to talk about like curing units. So there's a lot of controversy on this, and as with everything dentistry, there's a lot of common sense that goes into selecting materials. So these are just general guidelines for the types of materials and the types of applications. We can talk about more hypothetical situations when we have our discussion. But in general terms, you would use for a class 5, you use it either a microfill or nanofill, because this is an aesthetic region where you need a lot of polishability and you don't need a lot of mechanical properties. You use a mini fill or midi fill or a microfill nanofill for a class 4 like that. You could use every one of these types for a small class 1 restoration. You would not use microfills and nanofills for a larger class 1 restoration. And again, just as a reminder, a minifill is just a microhybrid. It's a minifill, which is a synonym for microhybrid, is considered to be a universal material. So in other words, the amount of filler, so you should go back to that table that I showed you in the first part of the lecture, is the amount of filler correlates with the mechanical properties. And the mechanical properties that are required for each one of those applications vary according to the location in the arch and the location on the tooth. And a class 5 restoration, even if it's in a posterior restoration, is not as mechanically loaded, or you don't need as much mechanical reinforcement for a class 5 as you need for a class 1, for example. So that's why you can use a microfill nanofill for a class 5, but you cannot use it for a larger class 1 in a posterior restoration. And the reason why you would prefer to use a microfill nanofill is because those are more aesthetic and more easily polished. And they have a modulus that's more similar to the dentin. So in this case, in the class 5 restoration, you want the material to be able to flex with the tooth. It's more important that the material flexes with the tooth at the same rate. So that's why you would choose microfills versus nanofills. With composites, you can actually mimic nature, and you're going to learn from Dr. Da Costa a lot about mamelons and doing all sorts of characterization on the tooth. But this is just a sequence for a class 4 restoration that, for something that can be highly aesthetic. So you start with a posterior shell, as we call it, a very transparent color. Then you add these mamelons here, that you probably learned from dental anatomy, with a more opaque dentin-like shade. And then you fill the rest of it up with an enamel. There's an art that goes into this, and you will learn. But you can see that the dentist actually even characterized a small chip that was on the other side, so that the tooth looks really natural. I mean, you can be really talented with this. Optical properties that we talked about in the materials, in the first section of the course. So fluorescence is a property of the tooth. So that means that the material absorbs light with a shorter wavelength and reflects light with a longer wavelength. So older composites did not have this fluorescence, opalescence type of, you saw opalescence in the optical property. And say if you go to a nightclub or a place where there's black lights, it appears like you don't have a tooth if you make it with a composite that does not have fluorescence. So you better be aware of that when you're making restorations for your patients, otherwise they'll come marching back and complaining to you that you did not pay attention to their aesthetic needs. So again, as we talked about at the beginning, causes for failure in composite restorations have to do with recurrent caries as more than half. More than 50% of the restorations are replaced because of secondary caries, 20% because of bulk fracture, and then others are wear, discoloration, and other reasons. And this is actually, there's a lot of different papers that show that this is the case, that recurrent caries is by far the main reason for replacement of the restorations. Now, this is a very important graph because it shows you a composite, an amalgam by a same dentist here on blue, composite, I can't read it. The green and red are composites and amalgams by the same dentist, and the teal and pink are composite and amalgams by different dentists. And you can see that for the same material, the rate of replacement or the rate of survival, this is taken from a Delta Dental plan, you can see that the rate of survival for amalgams and composites, if you stay with the same dentist, is much higher than if you change dentists, and it's the same for either material, which tells you that dentists do not trust of what our colleagues are doing, and they tend to replace a restoration if they see some discoloration, thinking that discoloration is caries. And not all discolorations are caries. They might just be staining. So other than aesthetically, you might not need to replace that restoration if it's just a caries, if it's just discoloration and not caries. And if the dentist knows the history behind the restoration, in other words, if the dentist was the one who placed the restoration, they're more likely to advise the patient to wait and see if this is going to go evolve to something worse. So anyways, changing dentists had the greatest effect on survival of either restorative material. Composite repair is something else that you will find it's a pretty controversial topic, and for you to be able to do that, there's, the bottom line is sometimes what happens is you have a large restoration that fractures. Instead of replacing the whole restoration, you might consider just doing a repair. You just have to know that the repair, the bond strength between the old and the new fragment, no matter what you do, is never going to be the same as a pristine material. So it's around 60 to 80% of the strength, of the initial composite strength. And to be able to do this and to increase the probability of success, you need to create an uncontaminated roughened surface with a burr or with air abrasion, then clean the surface with phosphoric acid, apply dental adhesive, and then apply the composite. So it's almost like you're doing another composite restoration on top of a composite restoration. And there's several papers that looked at the repair bond strength of different types of materials, and you're welcome to look it up. But the bottom line is you only have 60 to 80% of the initial composite strength, and with many things, as with many things in dentistry, you have to make an executive decision, a common sense decision on whether it's worth doing that or replacing the whole restoration. Now, we're going to talk about a topic that's very important that has nothing, has little to do with the material itself, but it has to do with the light curing units and how you're actually treating your material. And the first very important concept is the concept of irradiance and radiant exposure. So irradiance, or output, or power, or intensity, it's represented by the power per unit area in milliwatts per centimeter squared. So it's the irradiance is how much power, not energy. It's how much power you're putting in per unit area. The radiant exposure is the total energy. So that's the irradiance over the course of time. And that's the most important thing that you have to consider. Not the irradiance itself, but the amount of energy that's going into the composites. The amount of energy that correlates with the degree of conversion, not the amount of power. So the radiant exposure, or the total energy, can be calculated by multiplying your value of irradiance versus the exposure length, or the exposure duration. So you can get to the same energy, 16 joules per centimeter squared, if you polarize it with 400 milliwatts per centimeter squared for 40 seconds, or 800 milliwatts per centimeter squared for 20 seconds. You get to the same 16 joules per centimeter squared. And this goes back to talking about reciprocity laws. And I think we'll talk about it later on this. But you just have to remember that there are some lights, and we'll talk about this later, that there are some lights that are very powerful. They can put out 2,000, 2,300, 3,000 milliwatts per centimeter squared. And the manufacturers of those lights are claiming that you can just polymerize the composite for 2 or 3 seconds. And even though they're correct that you're going to get to the same energy, you will see the reciprocity between irradiance and, the reciprocity between irradiance and exposure time does not always hold true in terms of conversion and mechanical properties. So we'll talk about more of that later. But anyways, just remember that within reason, you can change the amount of exposure based on the amount of irradiance or the amount of power that your light is putting out, as long as you get to the same radiant exposure or total energy. So there's 2 basic types of curing lights. One is the quartz tungsten halogen, and another one is an LED, light emitting diode. So the advantages of the quartz tungsten halogen lights is that they're low cost. They have a broad bandwidth, which covers a lot of the initiators. And you see why that's important in a minute. There's different types of initiators with different wavelengths, and a broadband like a quartz tungsten halogen, you're guaranteed to hit all of the initiators, but it's very inefficient. It loses 99% of energy in the form of heat. So quartz tungsten halogens are very low cost, but they're usually not as powerful as LEDs, and they're also very inefficient. They generate a lot of heat. So LEDs, on the other hand, are solid-state semiconductors. They have a narrow bandwidth, which means they're more efficient. They still have a lot of waste, 93%, but it's a lot less than the 99 for the quartz tungsten halogen. They can be battery operated, and that's an advantage from the standpoint of convenience. It's easier, and they're smaller. They're easier to store, and you don't have to be dealing with cables in the patient, it's kind of nice. But they're narrow bandwidth, so you need to make sure that you're matching the type of initiator you have on the material and the lights that you're using to polymerize it. Here are 2 pictures of showing you the differences, what a good quartz tungsten halogen light is and another good LED light. And what I'm talking about, the compatibility with LEDs and the initiator comes into play on this slide. So for example, these are the emission spectra of different lights. So we're not going to look at the pack lights, but let's look at one LED versus another LED versus a quartz tungsten halogen light. You see that, well, especially if you're comparing this graph, you see a quartz tungsten halogen. Oh wait, sorry. If you look at a quartz tungsten halogen light and then you look at an LED light, you see that in this case, this specific LED had a much greater intensity than the quartz tungsten halogen. But that intensity was concentrated right at 460, 465, which is perfect for camphorquinone. The QQH would also, cover that wavelength, but a much broader band like that in a much lower intensity. So if you were to integrate the area under this curve and this curve, at the end it would be the same energy, but a lot of this energy in this case is not concentrated on the camphorquinone. The problem is some initiators that are used in more aesthetic materials, they are not camphorquinone. So camphorquinone is a pretty bright yellow powder. It absorbs at 465, it's visible light, that's why it's so yellow. But for some aesthetic materials, especially for bleach shades that are becoming more and more common nowadays, especially in the U.S., you can't use camphorquinone as an initiator. You have to use something that's a PPD, a different kind of initiator. It's a lighter yellow. It's centered at 400. But as you can see, the K2H gets to it very, very weakly. So, but there's a tail right there. But the LED doesn't even come close. So how do you polymerize those materials that are highly aesthetic with this single wave LEDs like this? This is the reason why some manufacturers more recently have come up with poly-wave LEDs. So you can see this is like glycerin TPO is the same absorption spectrum as PPD. It goes from 420 to 360 versus camphorquinone that goes from 420 to 540, centered at 465. And you see for an Optilux, which is a quartz tungsten halogen, you have a tail that goes into glycerin TPO, but the blue phase 16I would not go into that. So that's why they came up with the Velo and the blue phase G2 and the G-Light that not only have a wave that is centered at 468, but there's some intensity at 405 or 400, 414. So those light sources are compatible with those more aesthetic initiators. So you have to be aware of that. That some of the older models or single wave LEDs are not compatible with the more aesthetic initiators. And this is just a pictorial example of the types of ultra high intensity LEDs and their absorption spectra. So for example, this Radi Plus that's from SDI, which is an Australian company, versus the Heraeus Translux, you see that they get from 700 to 1,000 milliwatts per centimeter squared, so they're pretty powerful, but they're a single wave profile, versus the blue phase G2 and the Velo from Ultradent, blue phase from Ivoclar and Velo from Ultradent. You can actually see the semiconductor chips in here where they're blue or kind of ultraviolet, closer to ultraviolet. And this is what we call multi-wave profile. The Velo in the ultra high intensity can get you up to 3,400 milliwatts per centimeter squared. So what I was talking about with the high intensity versus short exposure times is that some of these manufacturers here for those lights are saying you can just you can look it up on their website. They are recommending 2 or 3 seconds exposures. And what this graph is intended to show you is a relationship between irradiance here on the y-axis and exposure time, and the values that you see in the middle are elastic modulus, so the stiffness of the material. What this line here is representing is a threshold value for the property above which it's the minimum required for good clinical performance. You have to be above like 7, for example. So you can see that if you have 1,000 milliwatts per centimeter squared, say if you have 1,000 milliwatts per centimeter squared for just a couple of seconds, you get to a modulus of 3 and not 7. Even though if you do 1,000 seconds at a much lower intensity, you get to about 9. So because the explanation for this is because those are cross-linked networks, and some of the diffusion limitations to the conversion take time. They are time dependent. You can't get to good properties if you deliver the energy all at once. It takes time for recycling of the initiators. It takes time for propagation to take place. So there is a temporal aspect to this. So in other words, the bottom line with all of this is, for one of the reasons why you don't want to believe that you can do super powerful LEDs for a very short period of time, is because that's not enough time for some of the properties to develop. So the light has to be on for at least 20 seconds, which is 20 to 40 seconds, which is what this is showing you right here. The other reason for that too is that there's a lot of heat generation in those very powerful LED lights, and that's the part that you have to remember. If you don't remember anything else about this class, remember that those very powerful lights put out a lot of heat. So if you leave that on the patient's, that on the patient's mouth for 10, 20 seconds, that can actually cause damage to the pulp. So you will see this in Dr. DaCosta's class, and Dr. Farrakhan and Dr. Hilton will also hammer your heads with this, is that even for the light sources that you have here in the pre-clinic, those are putting out 2,000 milliwatts per centimeter squared. So you do not want to keep those on for more than 10 seconds, 10 to 15 seconds. You're not going to use 20 seconds for those because they're very powerful. And they are, but you don't want to keep them on for only 2 seconds either, exactly because of this that I'm just explaining to you. All right? Because you're not going to get to the properties that you need. So there are some, I should actually have taken this slide out of the lecture because this is telling you that this is a material that's called a bulk fill material. And there's a lot of buzz towards the bulk fill materials now. And I should actually have removed this from the slide because there are better materials on the market that are bulk fill. But this was in the very inception of the materials when they were saying that you can do 4 millimeter increments cured in just 10 seconds. And I'm saying not in my mouth, right? At least not with enough evidence. Which is what this current status is supposed to be addressing. There's a lot of new materials in the market, and we can talk about those in a little bit more detail in class, but some of these recently proposed bulk fill materials are flowable composites. And there's several mechanisms through which you can make a bulk fill material work. So let's back up a little bit. Bulk fill material is a material that you can place in one increment in the mouth instead of doing the incremental layering technique that I showed you at the very beginning with increments that are no thicker than 2 millimeters. In this, you just dump everything in the tooth and polymerize it regardless of how thick the increment is. And there are several ways through which the manufacturers have made it sort of possible. One of them is to use flowable materials, and the rationale behind that is you have less of the filler particles, so you have less of the light scattering, which means the light can get farther down to the bottom of the tooth, which is true, but there's a trade-off with properties. So there's yet to be seen clinical trials where those materials were used so that we can actually use them safely. The idea with at least this 3M material that you can actually look and go into this website and look at this, look at their literature. What they're claiming is that you can fill the bottom of the restoration with their bulk fill flowable composite in one increment, and then just use the cap, a 2 millimeter capping layer of an aesthetic composite like Filtex Supreme. So in other words, you would put the layer that's in contact with the chewing forces cannot be flowable because, as you know, that has less filler and doesn't have as much mechanical properties. So you still need something that has a lot of filler to avoid wear, essentially. Anyways, you can do a case cat. You can do a case cat if you want to on research day, if you to look for this. And I think a lot of the DS3s are looking into this. DS3s and 4s are looking into this because they're going out in practice and seeing that some of those materials are the buzz now. Ivosiren is an initiator that's present in the Tetrix Evosiram bulk fill. And that initiator, so the reason why this bulk fill material works is because they came up with the different chemistry for the initiator that makes the initiator be a lot more efficient. And the initiator, let's see if I have a picture here, actually captures the light at the top and then propagates those radicals down. So this is the wrong material. Again, sorry, this is not the right picture for this. But the Tetric Evosiram bulk fill is what this Ivosiren correlates to. So I apologize for that. This is the wrong picture for this slide. And they have shown that there's definitely enough degree of conversion going on at the bottom. But again, there's not enough clinical evidence for us to recommend this at the dental school. Sonic fill from Kerr, you will see that that's a different way of placing a composite that does not use instruments, like metal instruments. It just relies on vibration to decrease the viscosity of the material, and that facilitates the adaptation to the cavity. And it's bulk cure because there's a lot of initiators, so they put a higher initiator concentration, and they put more translucent fillers. So there's not enough clinical evidence. We don't know if this is going to be as aesthetically pleasing, if the color palette for this is not as wide as some of the other materials. But a lot of dentists love to use the sonic fill because it's easier to adapt. You don't need to use those composite warmers. So just keep an eye out for this, because this is technology that's definitely coming to stay. But there's more studies that need to be done in terms of whether it's that much better than conventional materials. There are other materials that are now self-adhesive, and this current status is just, we can discuss more of those. We can discuss the papers in class, actually. So Vertiz Flow, for example, and Fuso Liquid from generic Pentrum, those are acidic monomers that are present into the composite, and they are, in theory, self-adhesive, so you would not need an adhesive before using this. They are flowable, and they are used as composite cement, as resin cements, so not as restorative per se. So, in summary, there's more than 66 brand names of composites on the market, and the challenge is how do you choose which one you use. They did a study saying that people usually use the material that they learned or that was available to them in the clinic and dental school. And manufacturers know that, so that's why they market those products so aggressively to dental school. So it's actually, we have to be evidence-based, to make ethical decisions. So there's a lot of things to decide from or to choose from, but the funny thing, the kicker, is that 85% of the market still BSGMA-based resins. So go Dr. Bowen. So from the 60s on, the significant modifications have been on the filler systems, not on the organic matrix. Those newly released low shrinkage monomers in the bulk fills and super fast LEDs, there's not enough clinical trials, and you should be weary of those. And we've been involved here at OHSU, as well as 5 other projects nationwide, to move away from methacrylate. So there's a lot of research going on in my lab, working with methacrylamide and working with iurethanes. So different chemistries to make new materials. So here are the kiddos after, I think Sherlock was a year old in here. So Napoleon has definitely lost some space in the couch. We will discuss this in class more in depth, and please let me know if you have any questions beforehand. And you should have watched this before the class on Monday.